It's a pleasure again to open up our series of interviews, this time with Dr. Laura Palagini. She is a professor of psychiatry with a very extensive experience in both psychiatry and sleep medicine. She has also a PhD in molecular and functional assessment of the nervous system. She has a very lengthy list of activities across different sleep societies, both in Europe and in the US. Most recently, she was distinguished with the award by the World Sleep Society on World Sleep Day in 2019. Also, Dr. Palagini has collaborated extensively around the world, mostly with colleagues in Europe and the US. So we have been very impressed by the track record that Dr. Palagini brings in her expertise. So good morning. And
good morning.
Laura, so in the context of the current worldwide health contingency, how is the population you're being served affected, and how is the present situation impacting your delivery of services?
Oh, that is a really important question. I want to say that during the lockdown, the situation was different. If you remember, here in Italy, we were maybe the first country outside Asia to be in lockdown. So during that period, everything was closed. Our sleep units, they were closed. And so I am a member of the National Association of Sleep Medicine. And so we wanted to support our patients because we were waiting for an increase in insomnia symptoms. And so we wanted to support people, and we create a program, and we were via Skype and emails in contact with everybody. But then I think after the lockdown, I think a lot of people experienced insomnia, but they are not coming to our unit for help. I think that a lot of people think that insomnia, even in this period, is just an experience, a human experience, and that could be just, transit, and it can go away by itself, but it's not like that. And that's why we are like an association of sleep medicine. We are trying to create a project, a kind of sleep videos like this, to increase the knowledge of people about the importance of sleep during this period, the connection between sleep and health. So we are creating videos like that, just to improve the knowledge.
Let me ask you, of course, with the pioneer work of Dr. Lugaresi in the famous and pioneer work of in the Republic of San Marino, where 13% of the population reporting poor sleep, later on confirmed that prevalence later on in the 90s in a national representative study in Italy. And with what you just said about the impact on the population and what is likely to be an ongoing challenge, how do you see the profile of the insomnia patient changing over time? If we were to repeat this conversation, and hopefully we will do it in a few years, what would you expect will be the profile of the insomnia patient?
Finally, after 30 years, we conducted another study in Italy. And so we just to know, I mean, how was the prevalence of insomnia? This time, we used a very famous questionnaire, the sleep condition indicator. And in this way, we could evaluate insomnia disorder according to the DSM-5, criteria. And we found that almost 50% of Italian people over 50, they were affected by insomnia. So it was really surprising for us. And these kind of people, they were especially women, and with a lot of comorbidities, not only mental, but also medical. For example, hypertension and cardiovascular diabetes. And so also we found that maybe in the last during the last 30 years, the lifestyle of Italian people has changed, and so I think we got this 24 hours kind of life, and we didn't have time for sleep, and so that's why I think that's why we found this. And
so talking about such a high prevalence and how the diagnostic criteria is set up currently with emphasis on the daytime consequences. And so is your approach to insomnia any different if the daytime consequences and or the comorbidities are not there?
I mean, it's important in this case, I think, the evaluation, because maybe a lot of patients, they come to me and they say, I suffer from insomnia. And then you evaluate them and they are just short sleepers. And so the approach is different. But if really after the evaluation, they really have insomnia symptoms, even if they don't have daytime consequences at the time, we have to start anyway, in my opinion, the therapy, because, as you know very well, insomnia is a risk factor for mental and medical, disorders. So we have to prevent the consequences of disturbed sleep anyway.
One of the things you have mentioned, and you certainly across your publications, it's clear that you truly believe on these comorbidities. And so what are the advantages and disadvantages of this concept of insomnia disorder, the current classification? Has it taken us a step forward in understanding insomnia, or just a comment based on your broad experience?
This question is it's very interesting. I'm happy with this classification, because in this way we have to consider insomnia as a psychiatric disorder, and also we have to evaluate it in our clinical practice all the time. That is very important. So this disease, I like it very much. So in my opinion, it is very good, this classification, because you have to consider insomnia and treat it in order, to modify trajectories of all the comorbidities. So I'm so happy about that.
Under the recently published consensus on the treatment of insomnia in collaboration with multiple societies, medical societies in Italy, and consistent with the worldwide approach to insomnia, your group, the group in Italy, emphasizes CBTI, and it is recognized that there is a limiting factor in providing that service to patients. But even if it was broadly available, uh, other than lifestyle modifications, what are the advantages or disadvantages? Under what circumstances would CBTI be impractical or contraindicated, if it would ever be a concern?
Um, I think that CBTI, okay, in Europe is not so widespread. In fact, I am a member of the CBTI Academy. We want to, improve the access to the CBTI therapy. And I have to say that I don't find contraindications. Measure contraindication, because we can adapt CBTI to almost all the comorbidities. I mean, at the beginning, we are saying, pay attention, don't do that in, bipolars. But now we have adapted CBTI for bipolars that integrated parts of therapy for circadian disorders. So I think is a really good therapy. We have just to improve, the diffusion of the therapy around Italy and Europe, because the first part of CBTI, the educational part, you can adapt this part to a lot of problems, not only mental.
No, and I'm happy you point out how it needs to be modified for bipolar disorder, because one of the concerns I had in questioning that is, we have almost an approach, one size fits all. And
Yeah.
clearly CBTI
Yeah.
needs to be modified according
Yeah.
to the other
Yeah.
comorbidities. So your point is very well taken. The other concern, of course, CBTI, as has been well documented, one of the most effective outcomes of CBTI is the restriction of time in bed. And
Yeah.
in the context of the growing literature on insomnia with objective short sleep duration, what are your thoughts not only about CBTI, but about the diagnosis and management of this phenotype of insomnia?
Yeah, that's a very good point. I mean, the work from Fernandez Mendoza and the group of Vonza is very important. We have to pay attention really to this kind of patients. Um, I think in these patients it is particularly important CBTI because in these patients, instead to do sleep restriction, we have to extend the time in which they stay in bed. So for sure, we have to really pay attention and to be very careful with the chronotype that they have.
Does your diagnostic approach changes? For example, in Italy, what percent with such a high prevalence of insomnia, who should get a PSG or some sort of wearable device to evaluate sleep? I'm not talking only about sleep apnea, but of course the objective assessment of sleep becomes very important and one that is challenging.
Yeah, I mean, it's difficult in Italy because we don't have so much sleep centers, but we have the possibility to use the actigraphic registration, and it can be useful in this situation, sure, for sure. It can be, it's important.
One of the aspects of your work which is unique is this assessment of affective temperament, on which you have published on bipolar disorder, but it occurred to me what should be, if any, the role of the characterization of affective temperaments in the evaluation of chronic insomnia, and perhaps independent of psychiatric morbidity. Does that give you any valuable clinical information?
Yeah, the study of temperament is something that is that my center in Pisa is very famous for that, because they my professor, they created a questionnaire to evaluate temperament. So I mean, it's something that is very important in our clinic. Considering insomnia, we have seen that insomnia is related to anxious and cyclothemic and irritable temperaments. So it should be very important to evaluate this aspect in subject with insomnia, because we can even predict more. I mean, it could be a factor that may predict, I mean, the future evaluation in I mean, insomnia is a risk factor for mood disorder. It could be more easier to find this trajectory if you evaluate temperaments and insomnia together.
And also going back to the concept or to the report on the consensus conference on the management of insomnia, there are comments about limitations on the chronic use of psychopharmacology, and there are specific comments about the Z drugs and benzodiazepines. So, but life is not straightforward, and in chronic insomnia, we find ourselves using psychopharmacology on a chronic basis. So in your opinion, under what clinical circumstances is it viable to continue these medications on a chronic basis? And of course, what type of follow-up do these patients require?
Yeah. You know, I was in a meeting just like last 2 days ago, yeah, last week, and we were speaking about this problem. I am against the use of these sedative hypnotics in the long term. It's just not me, because we have a lot of people that we have to treat the addiction to this kind of drugs. So what we were saying in the meeting last week, was that please to start other types of treatment. If you know that this patient is not coming back, if you cannot control, I mean, the use of this kind of drugs. So I don't think we should pay attention in the prescription of that. You know that during the COVID situation, we had a three times increase of hypnotic medication prescription. So that's very bad for us in Italy. It is a concern.
So what do you use? Not that there's nothing absolute, and I understand, but among your repertoire of options for chronic management in Italy, what are the options to go, so to speak? Not that that's a prescription for everyone, but you mentioned people at risk, and CBTI will only go so far. And if we truly believe on the consequences of insomnia, then we need to have viable options there. So, and in the absence of a consensus, so we need to talk to an expert.
Yeah. We use in the, I mean, CBTI obviously is the first approach, but I mean, is not there in the clinical practice. So especially in a psychiatry, clinic, it's so important to use melatonin. We have now in Italy this new medication is melatonin 2 milligram for longer release, And I think it's really important to use, especially, in a psychiatric context. And then we have some antidepressants, trazodone, that has some indications in all subjects, subjects with dementia and cognitive problems. So I agree with this kind of, therapies.
So switching to a somewhat different topic is this very important aspect of suicide attempts being identified as a potential consequence in cases of insomnia. And so what are the red flags that you would advise the clinician to consider when evaluating the risk of suicide in a patient with insomnia? And how different is the profile to the one observed in patients with psychiatric morbidities, independent? I mean, is insomnia an independent risk factor that statistically it's clear that it is? But, one of the concerns with insomnia disorder is that we have the mildest case of insomnia as long as they meet criteria to this extreme insomnia with suicide ideation or attempt, psychiatric morbidity. So it's such a huge spectrum of severity. So this issue of suicide, how do you approach it, and what are your thoughts about insomnia and suicide?
Yeah, I mean, it's so an important topic, and I'm studying this topic in patients with insomnia and in patients with the mental disorders. So I understood that the link is so straight because subject with insomnia, they have this hyperactivity of the stress system, and so hyperarousal, their emotional dysregulation related to all these systems that don't work. And I mean, there are a lot of factors that bring insomnia to suicide risk, to increase in suicide risk. I think that in the clinical practice, when you have a subject with insomnia, you have always to ask about it, about suicide risk, especially when people don't sleep in the middle part of the night and in the last part of the night. It seems that this kind of insomnia is the worst and is related to suicide risk. So I suggest to evaluate this point and to take this part of the night really in consideration with suicide risk. And so when you have to prescribe a therapy for insomnia, in this case, I will avoid, drugs that can become something that people can use for committing suicide. So I will avoid sedative hypnotic medication.
So one specific question there is at that degree of insomnia. Of course, there are likely some affective mood-related consequences. I mean, it's such a departure of good adaptation, if you believe that there is an adaptation from an evolutionary perspective. Is that insomnia a different type of insomnia, the patient that ends up with psychiatric morbidity, suicide, or is it's just an evolutionary part of the chronicity?
I think when there is the psychiatric comorbidity, I think there are a lot of mechanisms that may bring insomnia to suicide risk in psychiatric disorders. especially through the dysregulation of mood, because in this case you have emotion dysregulation, mood dysregulation, hyperarousal, disturbed dreams, because it could be, I mean, in insomnia, you can have also a problem with dreams and the hyperactivation of the stress system. And I mean, so this, in my opinion, all these are the links between insomnia and suicide risk in psychiatric disorders also.
Do those patients require a different follow-up? Of course,
Sure.
perhaps a huge proportion, and your research definitely confirms that, the huge comorbidity of psychiatric disorders. So how do you approach those patients different to the more garden variety insomnia?
Yeah, I mean, if there is a suicide risk with insomnia, we have a clinic, so they can be hospitalized, and we have in our hospital, in this, when they are hospitalized, we can study sleep with active registration with a lot of questionnaires, and then we can assess insomnia, suicide risk, the psychiatric comorbidity, and construct a personalized therapy for that. We normally hospitalize this kind of patients.
In concluding our most enjoyable interview, you had mentioned melatonin, and of course on the consensus paper it is identified. And I understand there are wide differences worldwide in terms of availability of melatonin. But you specifically mentioned the late release melatonin. And it might make some sense and some benefit, and here is the question. Is there a true benefit in the maintenance insomnia, in the early morning awakenings with the late release melatonin? Is that a clinically relevant improvement with it?
Yeah, sure. Because it is supposed to, I mean, the drug is very good because it's going all the night long. So that's okay, it's perfect for all the types of insomnia. And especially when insomnia is in mental disorders, is comorbid with mental disorder, is a symptom. And using melatonin, I mean, you can also use the fact that it's a chronobiotic agent. And so, because mental disorders, I mean, subjects with mental disorder, they can have a lot of problems with circadian sleep disorders. So by using melatonin, you can also resynchronize the problem with circadian rhythms. That's very important. That's why I trust very much the use of melatonin in mental disorders with the insomnia and circadian sleep disorders. The 2 milligrams prolonged release is a medication, and so it's important for me to know, how the drug works.
Do you consider adjustments on the dose of melatonin at all? I know the indicated dose is 2 milligrams, but it's not unusual to make adjustments based on clinical experience. So
yeah, sure. For insomnia, the indication is 2 milligrams. But if there is a circadian disorder, also you can adjust the timing of administration in particular, and the dose. Sure, yes, we have to adjust. If there is a area where we can personalize therapies, in my opinion, that's of insomnia and circadian sleep disorders is one of these areas. It's so important.
Laura, we have come to an end. It has been most informative, and we appreciate your help on the project that is widely available, and we invite people to send us their comments and suggestions for future interviews. Thank you so much, Laura.
No, thank you to you. I love this project. So thank you so much for, inviting me. Thank you. It was a pleasure.